Now I am going to discuss about how to manage critically ill COVID-19 patient. If you remember the severity classification, critically ill COVID-19 patients are the patients who are need life-sustained treatment. The patients belong to that group was patient with ARDS, patient with sepsis and patient with septic shock. If you remember the definition of ARDS, if you want to say this patient having ARDS, that patient should have newly onset symptoms of the respiratory symptoms within 1 week or progressive symptom within 1 week. He should have bilateral chest infiltrate. He should have pulmonary edema which cannot be explained by fluid overload or heart failure. Those three features should have in your patients. In addition to that, PF ratio should be less than 300. What is PF ratio? If you check your arterial blood partial pressure of oxygen, if I check my arterial blood partial pressure of oxygen right now, it says roughly about 100 millimeter mercury. I am taking right now 21% of oxygen from atmosphere. Then I am going to divide it from fraction of oxygen percentage in the atmosphere. Here 0.21, roughly about 500. My PF ratio right now roughly about 500. If I found a patient with PF ratio less than 300, I am going to call that patient having mild acute respiratory distress syndrome. 300 to 200, mild acute respiratory distress syndrome. 200 to 100, moderate acute respiratory distress syndrome. Less than 100, we are going to call as severe ARDS. Severe ARDS. So, if you want to tell your patient having ARDS, your patient should have within 1 week onset of symptom or worsening of symptom. Number 2, your patient should have bilateral chest infiltrate. Number 3, your patient should have pulmonary edema which cannot be explained by fluid overload or heart failure. Fluid overload or heart failure. Pulmonary edema should be there. So, your patient having ARDS now. If you want to categorize the severity, you can use PF ratio. 300 to 200, mild ARDS. 200 to 100, moderate ARDS. Less than 100, severe ARDS. If you have found a patient with COVID-19 and ARDS, you have to assess the severity of the ARDS first. If your patient having mild ARDS, that means PF ratio between 300 to 200, you can consider high frequency nasal oxygen, or you can consider non-invasive ventilation like CPAP and BiPAP. But again, you have to be very careful. You can't give prolonged duration. You have to give 1 hour first and assess your patient improvement. If your patient improvement, you can consider continuation of your high flow nasal oxygen or CPAP or BiPAP. If your patient deteriorate within that 1 hour, you have to consider advanced ventilator settings. If you want to give high flow nasal oxygen, sometime you will be in trouble. Why? High flow nasal oxygen sometime give 60 liters per minute oxygen in adult, roughly about 25 liters per minute oxygen in pediatric. So this time oxygen is very crucial. This much of oxygen wastage sometime not good for your hospital. So high flow nasal oxygen is, due to this reason, sometime may not be good. Number 2, if your patient having hypoxic respiratory failure, your high flow nasal oxygen might not be good. Number 3, if you are going to do CPAP or BiPAP, sometimes you can't predict tidal volume or transpulmonary pressure. How much of tidal volume you are going to give with the positive pressure, you can't predict. How much of transpulmonary pressure from here to here you are going to create, you can't predict. In that case, both can be injurious to your lung. You can't controllably ventilate your patient with CPAP and BiPAP. So in that case, both can be not good for your patient. In that case, CPAP or BiPAP sometime may not be good. That is why I told within 1 hour you have to assess your patient. Within 1 hour you have to assess whether it is improving your patient or not. In the past history also, MERS coronavirus, they tried with CPAP and BiPAP in the MERS coronavirus with ARDS, mild ARDS with the CPAP and BiPAP, but they failed. Here also most of the time you can fail if you are not carefully look at your patient. If you carefully look at your patient, CPAP and BiPAP might be very, very helpful. If you found a patient with deterioration with CPAP and BiPAP, or if you found a patient with acute hypoxemic respiratory failure with oxygen, you have to consider advanced ventilator support. You have to consider advanced ventilator support here. That means endotracheal intubation and controlled ventilation. Number 2. Number 3. Intubation should be done by most experienced person in your unit. Most experienced person in your unit. Why is that? He can easily intubate without contamination. Without contamination, you can intubate if you are the most experienced person in the hospital who doing intubation. So number 3, you have to do pre-oxygenation properly. Why? Your patient can rapidly deteriorate during the intubation process. 100% oxygen, 5 minutes you have to give some time. Especially the pregnant patient can rapidly deteriorate. Sometimes you have to do ambu ventilation prior to intubation. If you are going to intubate, it is an aerosol generating procedure. You have to wear personal protective equipment properly. You have to wear personal protective equipment properly. Number 4, ventilatory settings. Ventilatory settings, initial one, the tidal volume should be somewhere around 4 to 8 milliliter per kilogram of predicted body weight. 4 to 8. Plateau pressure, that means the maximum pressure generated in the chest cavity, the plateau pressure, not the maximum pressure, and after that if you stop expiration, or once you stop take inspiration and once you stop it, you come into plateau pressure, not the peak pressure, the plateau pressure. The plateau pressure should be less than 30 centimeter H2. You have to start with 6 ml per kg tidal volume. You have to start with 6 ml per kg per tidal volume, and permissive hypercarbia allowed. Little bit of rise in carbon dioxide. Usual carbon dioxide is 35 to 45 millimeter mercury. You can allow around 45 and 50 millimeter mercury when you are doing ventilation for patient with ARDS. Then if you found a child, the plateau pressure should be less than 28. Child lung compliance sometimes vary. If you found have lesser compliance lung, you may have to start tidal volume even 3 ml per kg predicted body weight. If you found have good lung, 5 to 8 ml per kg predicted body weight volume you can give. If you found have good lung. If you found have bad lung, sometimes you have to go even 3 ml per kg predicted body weight tidal volume. Then we are going to move into the PF ratio. Number 5. If you found a patient with PF ratio less than 150, you have to consider prone ventilation. What they found is it improved your oxygenation. You have to turn your patient into the face into the downside, and you have to consider prone ventilation. If you are going to do prone ventilation, at least you have to do 16 hours per day, 12 to 16 hours per day, in order to improve your patient. Then you have to use conservative fluid management. Unless your patient having hypotension or hypoperfusion of the tissue hypoperfusion or hypotension, you may have to give fluid. Otherwise, you have to think about conservative fluid management. Why? What they found is conservative fluid management reduces the lung water, then it will improve your oxygenation process. It will improve your oxygenation process. So conservative fluid management you have to consider. Then PEEP, positive end expiratory pressure when you are ventilating. When you are ventilating, you have to add positive end expiratory pressure in order to keep your alveoli open. It will reduces the work and it will improve the compliance. But sometimes it can crash your hemodynamic profile. Your patient can become hypotension with the high amount of PEEP. So PEEP should be individualized. Your station consultant anesthetist or consultant responsible for this patient will decide how much of PEEP should be given to your patient. So PEEP should be optimal for each and every patient. I can't give this one is optimal for COVID-19 patients. That is individualized completely. Number 8. In moderate to severe ARDS, that means the PF ratio 200 to 100 range. No need to give muscle relaxation. Sometimes you may have to give muscle relaxation in that range patient. If you found your patient become hypoxic further and further or hypercarbic, ventilatory dysynchronous is there, in that case you have to consider muscle relaxation. Otherwise, you do not going to give muscle relaxation in patient with moderate ARDS. In patient with moderate ARDS, no need to give muscle relaxation. It may be true in case of severe ARDS sometime. So, number 9, secretion clearance should be facilitated. Secretion clearance should be facilitated. Not only facilitated, it should be done within closed system. You have to apply closed suction to your patient. Physiotherapy you have to give. Don't disconnect your patient. You have to do closed suction without disconnecting from the tube. Avoid disconnection from the ventilator. If you disconnect, what happens? The PEEP you generate here completely going to be lost. Once you disconnect, PEEP completely lost. Not only that, you are in danger. If you are going to disconnect tube due to any reason, you have to wear personal protective equipment. Number 11. If you found a patient with PF ratio less than 50 for 3 hours or PF ratio less than 80 for 6 hours, you have to consider extracorporeal membrane oxygenation. If you found a patient with PF ratio less than 50 for 3 hours or less than 80 for 6 hours, you have to consider extracorporeal membrane oxygenation. That must be last option in the patient with ARDS. Here I am teach only about the ARDS management. Meanwhile, you have to consider other management like thromboprophylaxis, nutrition and other various physiotherapy and other various measures. That is all regarding the management of patient with ARDS. Thank you very much.